All right, let's jump right into this explainer. We're doing rapid-fire clinical rounds today, focusing strictly on vascular surgery and hemostasis exam pearls. Picture a 35-year-old guy, a heavy tobacco smoker, presenting with severe burning pain in his left foot. And this pain, it's there even when he's just resting. He tells you it gets way worse when his legs are elevated, but actually feels a bit better when he dangles his feet over the edge of the bed. He has zero history of high cholesterol, AFib, or heart valve issues. So what's the most likely diagnosis here?
The answer we're looking for is B, thromboangiitis obliterans. Now pay close attention to the spelling here because it's a classic trap. That severe ischemic rest pain tracking a dependency relief pattern in a young smoker, that is the absolute signature of Berger's disease, spelled with a U. It's a non-atherosclerotic inflammatory vasculitis. You really want to contrast this with Berger's disease with an E, which is IgA nephropathy. Totally different thing, that one's a kidney issue.
Looking at the pathology, it's characterized by these highly cellular, inflammatory blood clots jammed in the distal vessels. And here's the wild part. Unlike regular atherosclerosis, the internal elastic lamina of the vessel is actually perfectly preserved. But here is the absolute medical mandate: complete and permanent tobacco cessation. No exceptions. It's literally the single most effective intervention to stop this disease in its tracks and save the limb from digital gangrene and eventual amputation.
Now consider a 68-year-old diabetic patient in the vascular clinic. He's got these non-healing ulcers over his right metatarsal heads and severe pain at rest. You do a bedside ankle brachial index, or ABI. Which ABI range is the absolute strongest indicator of advanced critical limb ischemia?
The correct answer is E, less than 0.4. This essentially sets the standard reference framework for critical limb ischemia. An ABI plunging under 0.4 means that lower limb is imminently threatened and needs urgent revascularization. Just to give you the full picture, values between 0.3 and 0.4 usually correlate with severe rest pain, while anything dropping under 0.3 is a giant red flag for outright ischemic necrosis. For a quick comparison, a normal, healthy physiological baseline sits right around 0.9 to 1.3. But you've got to watch out for the artifact error. Sometimes you'll see falsely elevated ABIs, like 1.4 or even higher, in patients who are long-standing diabetics, have end-stage renal disease, or have Monkey-Burg's arteriosclerosis. What's happening is medial arterial calcification. The blood vessels literally become so calcified that they're mechanically non-compressible under a standard blood pressure cuff. When you see that, you've got to pivot to alternative testing, like toe brachial indices, pulse volume recordings, or transcutaneous oxygen tension measurements.
Take a 62-year-old man complaining of reproducible, tight, cramping pain in his calves. It happens like clockwork after he walks exactly 2 blocks, and it completely goes away after he rests for just 5 minutes. What is the expected baseline ankle brachial index range for this kind of stable, intermittent claudication?
The answer here is C, 0.5 to 0.7. This perfectly matches up with moderate peripheral arterial obstruction. The mechanics of it are pretty simple. When the patient walks, the metabolic demands of their leg muscles simply outpace what that narrowed stenotic arterial tree can supply. That's what triggers the pain, which naturally goes away once they rest. Oh, and keep this critical marker in mind. An ABI anywhere under 0.9 is actually an independent predictor for a silent heart attack or stroke. It strongly correlates with future cardiovascular mortality. When managing diabetic foot ulcerations, which are a massive clinical burden, which of these pathophysiological mechanisms is the least directly related to the immediate development and progression of those acute foot ulcers? The correct answer is D, glomerulonephropathy. Look, diabetic nephropathy is a very serious microvascular complication, for sure. It definitely shows us that the patient has advanced systemic end organ disease. But if we're looking strictly at the foot itself, the kidney disease doesn't exert a direct, localized, mechanical or structural force that actually triggers a foot ulceration or the progression of deep space tissue infections. The real culprits here make up what we call the neuropathic triad, which basically creates a perfect storm for unnoticed trauma. First, you have sensory neuropathy, meaning they completely lose that protective pain sensation. Minor scrapes or shear stress just go completely unnoticed. Then there's motor neuropathy, which causes the intrinsic foot muscles to atrophy, leading to claw toes and massive pressure points. Finally, autonomic neuropathy reduces sweating. That leaves the skin totally dry and cracked, acting as a wide-open portal for pyogenic bacteria to cause deep plantar space abscesses and osteomyelitis. In a totally different environment, a 40-year-old commercial scuba diver executes a deep dive but completely skips standard decompression protocols and shoots rapidly to the surface.
Almost immediately, he gets this severe, crushing bone and joint pain, tightness in his chest, and mild dyspnea. What's the primary mechanical process going on here?
The answer is B, an intravascular nitrogen bubble embolism. It's all about the physics of Henry's law. That rapid ascent causes a sudden, massive drop in ambient atmospheric pressure. Because of that drop, the nitrogen gas that was previously safely dissolved in the diver's blood aggressively expands into actual gas bubbles all throughout the vascular system and soft tissues. Clinically, this manifests in a few specific ways. You've got the bends, which is that terrible localized pain when gas bubbles get trapped in the joints, muscles, and periosteum. Then you have the chokes. That's when those bubbles track right into the pulmonary microvasculature, provoking chemical alveolitis and focal hemorrhage. Over time, chronic microembolic tracking can even cause casein disease, basically aseptic necrosis of the boneheads. The absolute only way to treat this is immediate hyperbaric oxygen therapy, inside a recompression chamber, to force that nitrogen back into solution.
Back in the OR during a KBG utilizing cardiopulmonary bypass, the surgical team needs to induce therapeutic cardiac arrest to protect the myocardium. Which ion is utilized as the primary arrestin agent in most standard cardioplegic solutions?
The correct option is B, potassium. Pumping in highly concentrated extracellular potassium violently shifts the resting membrane potential of the cardiocyte. This exact shift completely inactivates the fast sodium channels, effectively locking the myocyte membrane in a depolarized state. The end result is that the entire heart stops moving and safely relaxes in diastole. Stopping the heart in diastole is incredibly protective. It drastically drops the myocardial oxygen consumption, which preserves the cellular ATP reserves during the global ischemic cross-clamping. We multiply this protective effect by administering the solution cold, usually right at 4 degrees Celsius, for systemic hypothermic metabolic protection. We also toss in some magnesium, which stabilizes the cell membrane and limits intracellular calcium overload when we eventually reperfuse the heart. Postoperatively, if you suspect a patient is developing systemic DIC following a complex abdominal aortic aneurysm repair, which laboratory parameter is considered the single most useful and sensitive screening marker to exclude a diagnosis of DIC entirely if its value remains normal?
The answer is D, quantitative D-dimers. DIC causes widespread activation of the coagulation cascade, creating extensive fibrin clots. But that clotting is almost instantly followed by rapid secondary fibrinolysis. D-dimers are direct cleavage products of that cross-linked fibrin. Measuring them is a highly sensitive test, meaning if the D-dimer level comes back completely normal or negative, you can effectively rule out acute DIC.
But if DIC is present, it leaves a devastating footprint in your labs. That unchecked systemic clotting rapidly chews through your clotting factors. You're going to see severe thrombocytopenia, just depleted platelets, a prolonged PT and APT, a huge drop in circulating fibrinogen, and highly elevated fibrin degradation products. Because it consumes factors and platelets at the exact same time, it creates this terrifying paradoxical presentation: widespread microvascular thrombosis happening right alongside severe systemic clinical hemorrhage. In an emergency setting, treating an acute embolus-induced occlusion of the right common femoral artery, the surgeon asks for a Fogarty catheter to execute a thromboembolectomy. What exactly is the primary clinical utility of this standard device? Option A is correct, mechanically extracting thromboembolic clots. The standard Fogarty catheter is a specialized balloon-tipped vascular device engineered specifically for emergency arterial embolectomies. It's designed to physically drag acute clots or emboli right out of the arterial tree. The technique itself requires a lot of precision. First, you carefully advance the uninflated catheter all the way past the site of the thromboembolic occlusion. Once you're safely past it, you inflate that little distal silicone balloon with sterile saline. Finally, you gently withdraw the catheter using the balloon to physically hook and pull that clot right out of the arteriotomy incision. But here's the catch. These standard Fogarty catheters range from 40 to 80 centimeters long. Knowing that pulling an inflated silicone balloon through a vessel with excessive traction risks a catastrophic iatrogenic intimal rupture, at what exact point does our life-saving mechanical intervention risk becoming the very cause of a brand new surgical crisis?